Good morning, everyone. My name is Craig McLean, and I'm a pediatric anesthesiologist at Boston Children's Hospital and faculty at the program for global surgery and social change at Harvard Medical School. And I'm going to be moderating what is the last in the series of webinars that we're putting on. Today, I think you're going to find this a fascinating look at the role and value of anesthesia in the development and success of surgical systems. So I'd like to thank, I guess I should give you the title of the webinar. The title of this one is Anesthesia Getting to the Tipping Point. And this is the fourth webinar in the series From Pandemic to Progress, Building Capacity Through Global Surgical Obstetric Trauma and Anesthesia Systems. I'd like to thank the G4 Alliance for heading this up, as well as the Program for Global Surgery and Social Change at Harvard Medical School and the Global Initiative for Children's Surgery for sponsoring this series of side events at the UNGA this year, looking at surgical and perioperative care and the critical role of surgical systems in healthcare overall. Additionally, the American Association of Nurse Anesthetists, the International Federation of Nurse Anesthetists, the Nigerian Society of Anesthetists, Smile Train, and the World Federation of Societies of Anesthesiologists have all been vital partners in getting this particular webinar together and off the ground. We have thus far had webinars dedicated to surgery, obstetrics, gynecology, and trauma. And today we're going to focus on the anesthesia aspect of surgical systems and the value of such clinical services in effectively dealing with the shifting needs of overall healthcare system, in particular dealing with crisis events such as the current pandemic. The webinar today will be broadcast in English, French, and Spanish. The French and Spanish interpretation is being generously supported by both Operation Smile and Smile Train. So thank you very much for helping with that. So I wanted to give a little background and some food for thought for starting. We're living through unprecedented times with crisis upon crisis dramatically affecting the entire world across a variety of dimensions, healthcare, economies, immigration, and climate change among them. As anesthesiologists, nurse anesthetists, and other anesthesia providers who are all citizens of the world, we realize that the current crisis of COVID-19 is really grafted on top of the longer-term crisis we are acutely aware of on a daily basis, namely that billions of people throughout the world lack access to safe and effective anesthesia. The Lancet Commission on Global Surgery represented a seismic shift in how the global health world would be forced to think about surgical and perioperative care. No longer could this side of medical care be viewed as only necessary for the privileged few. Rather, the Lancet Commission demonstrated that 5 billion people worldwide, and that includes 1.7 billion children, lack access to safe and effective surgical care, including safe anesthesia. This shows that this is unequivocally a public health crisis. I won't go into the details of the Lancet Commission report as they have been discussed ad nauseum elsewhere, but a tremendous driver for this disparity is the lack of access to safe and quality anesthesia. In global surgery, we often take the principles of what we all do as perioperative caregivers, what we do in a single operating theater, and apply them to larger public health problems. And rather than focusing on a single disease or pathology, we look to build functional surgical systems as part of universal healthcare that can then deal with a variety of diseases, pathologies, and problems effectively. The obvious issue that functional surgical systems can help tremendously with at this moment is the current pandemic. A linchpin of a functional surgical system is safe and effective anesthesia. For example, a recent report by McKinsey & Company showed that bed capacity, and this includes many critical care beds, can immediately be increased by 30% by ceasing non-emergent surgical cases. Further, perioperative caregivers, including anesthesiologists, surgeons, nurses, and techs, are uniquely positioned to pivot to care for the influx of patients that would occupy these beds. They can do this due to expertise and experience with dealing with critically ill patients, as well as knowledge of ventilator management. So simply utilizing existing space and staff from a well-developed surgical system will yield tremendous benefit to the overall healthcare system. Paul Farmer famously stated in 2008 that global surgery was the neglected stepchild of global health. And when the Lancet Commission launched in Boston in 2015, I noted that anesthesia is the invisible friend of that neglected stepchild. And unfortunately, that remains the case to this day. However, there's a lot of reason for optimism and hope. There is great progress being made, as will be evidenced by the talks that are given today. Today's webinar is going to look at a variety of perspectives as they relate to the development and maintenance of such a functional surgical and overall healthcare system, with particular respect to the role of anesthesia provision within that system. The WHO has identified 3 major messages for the UNGA this year. The first is equitable access to COVID-19 tools. Anesthesia providers are uniquely positioned to deliver on this concern, particularly with critically ill COVID-19 patients. The second message involves maintaining momentum towards achieving the Sustainable Development Goals. And clearly, development and maintenance of functional surgical systems has a massive role to play in this. And once again, anesthesia providers will play a major role in ensuring billions of people around the world can reach these goals. Finally, the third message is that we must prepare for the next pandemic now and together. Functional surgical care systems, including safe and quality anesthesia services, will be critical components of this preparation. We have the opportunity to develop better responses that incorporate anesthesiologists, surgeons, nurses, and demonstrate the incredible value of a functional and effective surgical system. So today we have a wonderful lineup of speakers, very diverse too in terms of clinical roles, research roles, geography, and perspective. I'm going to introduce each speaker, but due to time constraints, my introductions are going to be a shell of the real story behind each speaker. Everyone here has an unbelievably impressive CV, and I apologize for not doing them all real justice. Once again, I thank everyone for their interest and attending this webinar as we attempt to get to that tipping point in anesthetic care and truly reach healthcare equity across the world. So our first speaker today is, oh, I'm sorry. If you guys have questions, please put them in the Q&A button at the bottom of your Zoom screen. And for any comments, you can put in the chat. And the plan is to have some discussion at the end, and we'll try to get to everybody's questions. So thank you. So our first speaker today is Dr. Zipporah Gatuya. She is a pediatric anesthesiologist who is working in Nairobi, Kenya. She serves as the secretary for the Global Initiative for Children's Surgery and is a member of the Global Medical Advisory Board for SmileTrain. The title of her talk today is Using the COVID-19 Pandemic to Strengthen Anesthesia and Critical Care Systems in Africa. So go ahead, Zipporah. Thank you.
Thank you very much. You can hear me? Speaking from Nairobi, Kenya. COVID-19 was first case was reported in March 2020 in Kenya. And several things followed that showed us that we really needed to have strengthened anesthesia surgical systems. Next. The realities that we faced at that time was the lack of infrastructure for critical care and anesthesia. There were very few critical care beds. There were very few spaces. There were some parts of the country that had no critical care beds. There was lack of trained workforce to handle the rising numbers or what was projected to be the numbers that would be at the end of as we went to the peak. And of course, there was also the lack of equipment. Further realities that were brought to the fore was the lack of oxygen. There were very many health facilities that didn't have reliable oxygen sources and supply. And there was also lack of mechanical ventilation and high flow oxygen, like with nasal cannula, which were said to be necessary to support these patients who were going to have severe COVID-19 disease. As part of the realities, we realized that there were also a lot of collateral damage that was going to occur from the COVID-19 disease, including canceled elective cases. So what happened is that when the first case was diagnosed, after some time, when the pandemic was declared, all elective cases in the whole country were canceled. There was also a lot of fear among the populace of the country. So that meant that there was also late presentation for emergencies, and the lockdown did not help the issues better because people could not get to the hospitals because of the curfews and the lockdown. There was also patients with comorbidities who could not get their medications on time. Children were missing their immunization. There were cancer surgeries that were not happening and diagnosis, and all these, we can call them as collateral damage from the COVID-19. And of course, the ultimate lack of personal protective equipment. But with those realities, what opportunities did we get as a system from this COVID-19? The first one was the realization from the government in the need to invest more in health facilities, in critical care, and especially in delivery and access to oxygen. All these will be of great benefit to the anesthesia system and critical care system. All of a sudden, people realized the importance of having people with critical care training. Some counties had no, our health system is divided into national government and county system. They had no critical care beds, and these had to be worked on very quickly. And then with this now increased bed capacities, it means that going forward, even in counties that were not able to do complex anesthesia or surgical skills, they are now going to be able to do that post-COVID because the beds are now there, there is oxygen, the infrastructure has been improved. So we say it was a blessing in disguise that now all over the country we have access to critical care beds, we have access to oxygen in the operating rooms and oxygen in the ICUs or critical care spaces. The other opportunity that came with COVID-19 is the local production of personal protective equipment. We remember that the whole world was shut down. Everybody, even the big countries who were also needing PPEs, so the space to even import or buy from these countries was not possible because they were keeping what they produced for themselves. So as a low middle income country, we had to devise ways of producing our own PPEs. And now these have become accessible, they are cheaper, and they are useful, and we know how to use them. So that was another opportunity. The other opportunities that came with COVID-19 was telemedicine. Because we have said there were very few people with training in critical care, especially physicians, the Kenya Society of Anesthesiologists came up with a prospect of adopt an ICU, where all these new recreated ICUs that did not have personnel were assigned somebody from the hospitals that were already running ICUs who would adopt that ICU. And if they got cases, would work with them. They can talk to them on the phone. They can do WhatsApp calls on them or Zoom and be able to take care of the critically ill patients in a remote area than where you could be physically. The other thing that happened is that there were very many webinars. I'm sure most of us have attended a lot of many webinars, including like this one. and education opportunities. And we realized that the Kenya Society of Anesthesiologists have been running a weekly webinar, and we've had people joining in from all over the world with very high numbers, as high as more than 200 per week, on various things, which had not been feasible previously. When we used to meet physically, would have only maybe 20 or 30 people meeting. And this has also been true for the CMEs that we have held. And the other thing is about innovation. We've had innovation in prevention of transmission of infection. This has been great in terms of what the infection prevention control policies have been. And this goes beyond the COVID issue. I think this going forward will also minimize the effect of infection as a general in our healthcare practice. The other thing that has happened from COVID-19 is the advancement of regional anesthesia, because then we don't have the fear of aerosolization. People have had to become very good in doing their spinals, their epidurals, their nerve blocks. And there's been a lot of teaching on this, because then we don't have to worry so much about aerosolization. So in as far as it is possible, then we use regional anesthesia. And of course, the other thing is the advancement of teamwork. We've realized with this COVID-19 that people have to work together, the public health officers, anesthesia, surgeons, nurses, infection prevention people. Everybody has to work together to make it into one big system. So in totality, we can say that even though the realities were looking very grim when we started with this COVID-19, we have realized that there is a lot of opportunities. There is a lot of learning spots. There's a lot of things that we can do to make these going forward. And as we prepare for the next pandemic, then we will be better placed. And I think all in all, this pandemic has left our anesthesia and surgical systems in a better place than we were before it came along. And thank you very much.
Thank you, Zipporah. That was fantastic. Our next speaker is Dr. Jannica Mellon Olsen. She's an anesthesiologist in Norway who serves as the president of the WFSA currently. She's a past president of the European Board of Anesthesiology and has served as secretary of the European Society of Anesthesiology. The title of her talk today is Anesthesia, WHO Surgical Safety Checklists.
Dear everybody, thank you very much for inviting me to speak to you all today on this Sunday. I was asked to talk about the WHO surgical checklist because it has been around for a while, but still there are problems with implementation. So I'll talk something about these. I do have some conflicts of interest, but that's mostly organizational, and the only place that pays me money is my hospital. As you said, I am the president, the outgoing president of the World Federation, and we, as you know, we assemble all anesthesiologists in 150 countries around the world. And some of the most important things we do is trying to reduce the gap in surgery, safe surgery. As it was mentioned, 5 out of 7 billion people, 2/3 of the world, do not have access to safe surgery and anesthesia. And if you ask, next please, if you ask clinicians what are the problems, and that's also the statistics, is that the problems that people are dying from is very much due to teamwork and postoperative bleeding and infection. So what they have done to that, what has been done is of course developing a checklist. And next please. We know mistakes happen all the time. And here are some examples that you all will recognize for your own settings, including us in the high-income countries. Wrong medication, giving wrong blood, not cross-match, and swab left in the patient, and also wrong-sided blocks and surgery. Thank you. And we use checklists every day. As you can see here, some examples. One is just a shopping list. To ensure that you remember all important issues, you write down what you need to shop. And of course, the most famous is from aviation, as we all know. And we discriminate between the regular checklist, normal checklist you do before takeoff and so on, and landing and those things, and then you have emergency checklists. I'm not going into emergency checklists here, but they have been around in aviation for 100 years almost now. So we know that that's helpful. Next. And to mitigate some of that, there were clinicians coming together to develop the WHO guidelines for safe surgery, as you are aware. One of the main issues here is that you remember to do everything, check everything in the first round, and then, of course, improve teamwork and communication, which is very important. And it has been shown that for several years, there was no real reduction for patients' deaths and so on in surgery. So we needed to come up with something new. And this year, it's 11 years since the safe surgery checklist came around. And I'm sure you all are aware of the setup, but I will go shortly through them. It's not about an algorithm. It's a series of checkpoints. Next. Here, you all are familiar with that, but I will go through some parts. Next, please. It's in three versions of 3 divisions. One is before the induction of anesthesia. And I'm not going into details because you know them all. I'm sure you all know about them. Next. Then before starting surgery. And then finally, when surgery is finished and you check out of the operation. Next, please. So the thinking before the checklist was introduced is that the checklist might save as many as half of those patients that would otherwise have died, and much more that would have been injured by the lack of procedures. And that would mean that the potential when they started was that you could save 500,000 lives every year, which is amazing. Next, please. Next. So the most important now is the impact of the WHO, because in the beginning, as you remember, there were some journals or some publications doubting whether it was smart to do the checklist, if it really helped. And there were others that found out that if you do it the right way and so on, it helped on other things than what the checklists checked. So the outcome of surgical bleeding and cooperation, many things that were not in the checklist, they also improved. And this is a recent publication from last year in Anesthesiology. And it's interesting because it has been published by a nurse anesthetist, a psychologist, and an anesthesiologist physician together, illustrating somehow, I think, that how a good teamwork can make good outcomes. And what they found at that point is, of course, what we all know: implementation is the most thing. So if a checklist shall be valuable and useful, then you need to have a good implementation, and you need to find that everybody on the team are together. And particularly, it's important to get the surgeons buy-in here. And I'm sure that in your countries, you have experienced the same as we have in my country, that the surgeons, particularly in the beginning, they, aha, I don't need that, this is stupid, and so on. But just the fact that you get everybody to say their names, that has been shown to improve the outcome for patients, because then everybody can speak up. It's easy when you have just told your name. And we have found that if you use opinion leaders and try to find those opinion leaders that are positive, they will impact everything. So at least in my hospital now and in my country, it's more than 90% to follow the checklist every or most of the time. Next, please. I'm approaching the end of my presentation, but as this is a COVID-related webinar, I would also like to drive your attention to this checklist, which is developed now in the COVID area, and it's about an intubation and extubation checklist. Next, please. If you don't know where to find it, you can go to the WFSA's website, where we have combined a lot of resources for coronavirus in high, middle, and low income countries. So please go there and use that checklist. Next. And checklist, I would just also direct you to another publication, and that is our International Standards for Safe Practice of Anesthesia, which we have developed together with the WHO as a resource. And to finish off, I would like to go back to more than 10 years ago, and to say that the mistake is that an assumption that a technical solution can solve a cultural problem. The culture must come from the top, and changes must come from the top. And the technical and adaptive work is very important. You cannot think you have done the job just because you have a checklist. Next. And nothing threatens safety so much as complacency induced when an organization thinks that the problem is solved. You have to follow and work on this every time. And next. Thank you very much. We are together in this war against Corona. We are again together in the fight to solve the pandemic, and we are using checklists when it's useful. Thank you very much, everybody.
Thank you, Jannica. That was fantastic. Our next speaker is Dr. Obushina Ogunbiyi, who is a consultant anesthetist in Nigeria, where he is a retired major general, as well as having served in a variety of positions in national anesthesia and critical care organizations. You can see from this slide, it's a long list. He is currently serving as the coordinator of the critical care pillar of the Nigerian national COVID-19 response. And he's going to give us a talk today entitled COVID-19 and Resource Limited Climb, a Lagos, Nigeria experience in tipping the frontiers of critical care manpower requirements. So, Sheena, thank you very much.
Thank you so very much, Craig, for the wonderful introduction. It's indeed a pleasure for me to be present here today as one of the guest speakers. I'm going to speak on COVID-19 in resource limited climb in Lagos, a Lagos, Nigeria experience in tipping the frontiers of critical care management requirements, manpower requirements. And I remain the coordinator of the Critical Care Strategic Unit of the Lagos State Emergency Operations Center for COVID-19 response. Next slide, please. As a form of introduction, the COVID-19 disease is a rapidly evolving novel coronavirus infection which affects the respiratory system mainly. And on 11th March 2020, it was declared a pandemic by the World Health Organization. And till date, there is no cure for this disease. The United Nations Economic Commissions for Africa, UNECA, sometime in March, did say that there may be a high burden of disease in Africa. And they indeed said that there may be about 300,000 deaths as a result of this pandemic in Africa in the year 2020. However, this has not been so. Globally, as at 15th of September 2020, there are 29,331,467 cases, confirmed cases. And it may be interesting to note that over 15 million of these cases alone are from the United States, Brazil, India, and Russia. On the other hand, as at this date as well, that's 15th September 2020, Africa has 1,379,282 cases, confirmed cases, with only 33,294 deaths, unlike the predicted about 300,000 deaths by the end of this year. However, Nigeria, with an estimated population of 206 million, according to the United Nations, has about 56,478 cases and 1,088 deaths as at the same 15th of September 2020. Some of these deaths have been attributed to a dearth of appropriate critical care intervention. As mentioned earlier on by our first speaker, we have a challenge in terms of number of critical beds available in the country, number of intensivists, skilled intensivists. These are some of the challenges that led to some of these deaths that were recorded in Nigeria. Next slide, please. Our first index case in Nigeria was confirmed on the 27th of February 2020. And this happened to be the first in sub-Saharan Africa and the third in Africa. If we remember, the first case in Africa was actually confirmed in Egypt, and ours was the third. It's in a 44-year-old Italian that arrived the country 2 days earlier from Milan in Italy. He was the first and the index case that brought this COVID-19 into Nigeria. From the early records in China, in the study conducted by WHO and the Chinese authorities, they found out that about 14% of the cases are severe, while about 6% of critical cases end up in the ICU. And this as well have been the same picture in most of the European countries affected by this COVID-19 disease. The Lagos State established the Emergency Operations Center for COVID-19 response shortly before the first case arrived in Nigeria as a proactive measure. And some of the pillars in this EOC are the surveillance and epidemiology pillar, case management pillar. The intensive care units subunit is under the case management pillar. And also there are the psychosocial pillar amongst other pillars. And with the rate at which critical care patients were being ventilated in China, in Italy, in Spain, and so on and so forth, the Lagos EOC proposed a 5-bedded ICU intensive care unit at the mainland hospital Yaba. Our first index patient was actually managed at that mainland hospital Yaba. Next slide, please. Sorry, the last slide showed the picture of the index patient who, yes, thank you. The index patient, this was when he was being discharged after treatment at the mainland hospital Yaba. What are the challenges, some of the challenges that we faced in our Lagos Isolation Center? There was a dearth of skilled intensivists, as I mentioned earlier on, and critical care nurses as well. And access to oxygen usage was also a challenge to us. This may be due to the fact that there is actually inadequate healthcare funding existing before the COVID-19 pandemic came in. And also there was challenges with oxygen supply chain. Most of the hospitals don't manufacture oxygen themselves, but depend on other organizations like the British Oxygen Company and so on to manufacture oxygen, and then they now go and get oxygen in cylinders. We face the same oxygen challenge at this time as well. Also, the number of critical care beds in the country is not adequate. And of course, the consumables, we have challenges with them as well. So in terms of manpower resources, there are one or two ways by which we can actually mitigate these challenges. Nigeria presently has about 55 certified and practicing intensivists. And I want to state here that half of this number are domiciled in Lagos. Unfortunately, or however, they work in either the tertiary hospitals, some are in private practice, and only very few of these work in the state employ. And also, no individual facility on its own can set up an ICU. I'll quickly go to tipping the frontiers. How did we overcome the challenges? It's pertinent to note that increasing ICU beds and workload without increasing the staff could result in increased mortality. This is the main challenge that we needed to mitigate. And the Lagos State government seconded about 3 intensivists and 3 critical nurses to the 5-bedded ICU. Also, physicians and anesthetists from the state general hospitals were drafted without having challenges to the clinical services in their main hospitals. Also, a 3-day didactic short course on general intensive care plus advanced life support course, which is American Heart Association certified, was carried out in 2 batches of doctors and nurses to familiarize them with the COVID-19 management of patients in the ICU. Also, the Federal Ministry of Health organized a train-the-trainer course on COVID-19 case management for 3 weeks throughout the 6 geopolitical zones of the country. And yours truly was one of the resource persons during this course. We also noted that there could be loss of staff to illness or quarantine after unprotected exposure to COVID-19 in the healthcare environment. So what did we do? We tried as much as possible to limit unprotected exposure. We reassured staff through IPC training and IPC measures as much as possible. Showing on the right is a snapshot of participants at the 3-day didactic lecture on intensive care unit management of COVID-19 patients. Next slide. Next slide. Another challenge that we faced had to be, other slide, please. Had to do with minimizing the risk of healthcare worker infection. Ideally, we're supposed to have a negative pressure room for the intensive care unit because of the risk of the COVID-19 droplet transmission of the COVID-19 for healthcare workers. However, because of costs, we have to engage policymakers constructively. And in doing this, a compromise was reached to have HEPA filter purchased for use in the COVID-19 specific intensive care units. On the right is a chart of cases that were seen in our COVID-19 ICU at the mainland hospital, Yaba, Lagos. About 64 COVID-19 patients were seen in the course of between May and August 2020 at the mainland hospital, Yaba. We had 33 mortalities. However, it's pertinent to note that none of the healthcare workers there was infected because of measures that were put in place. In conclusion, I want to say resource-limited countries are faced with manpower challenges as a result of the ongoing COVID-19 pandemic. And the scale of the challenge here with COVID-19 had not been as much as was envisaged by scientists and others. However, there is also a dearth of skilled critical care personnel, which was one of the challenges. And to mitigate this, the Lagos State government, through the Emergency Operations Center, encouraged training of 2 batches of physician anesthetists, medical officers, and nurses through short courses in ICU management and COVID-19 protocols and guidelines. And this produced a successful increase in critical care personnel to run the cumulative 25-bedded COVID-19 ICU in the 3 isolation and treatment centers in the state. These successes, I dare say, were due to teamwork, steadfast leadership of the critical care strategic pillar, and a very avid support of the Lagos EOC leadership, and also the constructive engagement of the hospital administrators and relevant policy makers in Lagos state government were the factors that led to the success of mitigating the challenges of manpower challenge in the intensive care unit, COVID-19 intensive care unit in Lagos. Thank you.
Thank you, Sheena. That was fantastic, and kudos for such a tremendous job in Lagos.
Thank you.
I see that there's over 230 participants right now in the webinar, so this is fantastic. So we're going to continue on. We have a few more talks. Our next speaker is Dr. Carolina Haylock-Lure. She's an anesthesiologist, intensivist, and interventional pain physician in Honduras. She currently serves as the president of the Honduras Society of Anesthesia, Reanimation, and Pain Therapy. And she's going to give us a talk today entitled Time of Crisis, Time for Safer Anesthesia in Latin America. So Carolina, you have the floor.
Thank you very much for the opportunity of sharing how Latin American anesthesiologists are doing to move forward during this crisis. Well, next slide. This is the picture of Latin America, the big picture. Our region has more than 612 million inhabitants with almost 7 million of cases of COVID-19, around 265,000 deaths. By the other hand, we are more than 56,000 anesthesiologists, which comes to a density of 9.24 anesthesiologists per 100,000 inhabitants. And with this crisis as scenario, given the next slide, please. And with this crisis as scenario, the anesthesiologist stands out stronger in our region. And I would like to take your attention to a historically proven model in Latin America, almost 25 years, effective model, regardless of poor infrastructure, equipment, and lack of medicine sometimes, and is becoming a pole of global influence, and is the model one-to-one, one anesthesiologist, one patient. During this surge in the region, people have seen the anesthesiologist as a highly qualified physician that has played a crucial role in this pandemic, as seen in all Latin American countries. Also with a fast adaptive capacity to critical care and other fields related to anesthesiologists, like it happened in Chile, and with a versatility movement typical of the specialty to perioperative medicine. So we think it's time to reinforce this model with our governments, our academia, for providing a safe, accessible, affordable, timely anesthesia for everyone, especially in public systems with rational and a balanced geographical distribution. We are almost 60,000 anesthesiologists in the region, and we are focused to continue this model. Next. And for building capacity in anesthesia, we continue working for more significant growth potential and betting on further expansion in our specialty. Training programs for anesthesiologists with global vision, and unifying programs with scientific and practical solidity. We are encouraging health and university authorities to promote the training of anesthesiologists by opening more places for trainees and for physicians to distribute to inland hospitals. Definitely more significant numbers of jobs are needed. Why physicians? Well, because in our region, the physicians take care of many health problems in the perioperative, allowing this care to be much faster with a greater benefit for the patient and less cost for the state and society, especially during a pandemic. Next slide. I'd also want to highlight the role of CLASA, Latin American Confederation of Society of Anesthesiologists. CLASA has worked proactively, building capacity by education, innovation with online courses. For example, just starting this pandemic, CLASA had webinar series aiming for giving knowledge as early as possible to the members of what was going on with this disease and how to overcome this challenge. Clinical knowledge, also patient safety and anesthesiologist safety. Teamwork is crucial, but team well-being is more crucial to get ahead of this crisis. All that was treated by, given by CLASA. Another example is what airway management training courses in Latin America doing. EVALA, that's the name of these courses, now going online, as well as essential pain management online courses. Ventilation modalities, training with hybrid models online and on-site as telemedicines, and congresses going online. Also, CLASA is working for a unified certification with Latin American anesthesiology diploma, seeking in the specialty a training in intensive care with academic support. Next slide. I'm gonna say just a few words about COVID-19 in Latin America. Last week, in the region, around 7 million cases and more than 264,000 deaths reported. And as you know, in the world, we have more than 7,000 deaths in healthcare workers. And I must highlight that Mexico is the country with more deaths in healthcare workers, 1,320, followed by United States and then Brazil. And these numbers also translate into anesthesiologists, 113 anesthesiologists falling in battle in the region. It is a situation that gives us much regret and pain that colleagues and persons part of our teams die, especially if it's related to lack of safety environment. Next. So providing a safety environment for anesthesiologists is a priority now more than ever. Not only in physical safety, which of course is determinant, like providing enough PPEs and training and having government support, and several anesthesia societies did in Latin America, supporting OR teams by fundraising and addressing donations for safe teamwork. And just to say, we are grateful for all the collaboration of national and international organizations, WFSA, Lifebox, USAID, and so on. But also it is important to be aware of workload, aware of burnout, of depression. Several national societies in Latin America and also CLASA provided counseling during this pandemic, because you can't ignore the impact, the emotional impact, the spiritual impact, how to cope personal fear, worries about family care, economical constraint, etc. We heard that they call us heroes, but sometimes heroes without support. It was not uncommon to see violence and discrimination against healthcare workers in our region. Next. And for ending, some lessons learned. As I said in this presentation, the first lesson learned during this pandemic for us is that anesthesiology is one of the most versatile and adaptable specialties, something demonstrated during this crisis. The second lesson is that we are all learning, not just medicine, but also holistic aspects of life, the value of life, the value of family, the value of a friend, the value of unity to overcome this crisis, the value of a full PPE, of course, and very important now more than before, the value of a good internet signal. Thank you very much for your attention.
Thank you, Carolina. Wow, some sobering figures. You know, I take my hat off to everybody who is holding the hands of patients while they walk through this very difficult time, and putting themselves in harm's way and demonstrating that as anesthesia providers, the patient comes first. Our next talk is going to be from Dr. Janet Martin. She's an associate professor in anesthesia and perioperative medicine and epidemiology and biostatistics at the University of Western Ontario in London, Ontario, Canada. She serves as the co-director of the WHO Collaborating Center for Global Surgery, Anesthesia, and Perioperative Care at the university there. She has a ton of other very recognizable things I could say, but I'm just going to let her talk. And the title of her talk today is As Strong as Our Weakest Link, an intersectoral assessment of universal access to SOTA care.
Well, hello, everybody. Thank you so much for this opportunity to be part of this global panel with distinguished colleagues from around the world. A true pleasure. What I'd like to talk about today, being as strong as our weakest link. My thesis is going to be that we need to have an intersectoral assessment of access to universal SOTA care. And in order to do that, we're going to need to make some changes. When I think about global surgery and anesthesia and our progress, I would have to say that great strides have been made. However, I also, when I reflect back, I sort of think of this as a movie where sometimes it seems to be going in slow motion, and other times, especially recently, it seems like we're on a fast forward reel. So it all started, if 2015 was our banner year, with the release of the World Health Assembly resolution, the DCP-3, as well as the Lancet Commission, we could say that our efforts and our volumes and our quality of surgery, at least, and the attention on it was going up. And then we had the COVID effect, whereby our surgical volumes went precipitously down. And in fact, I think we may have reverted several years, even decades in some countries of the world in terms of our access to surgery very suddenly during the peak COVID period. So if 2015 was our banner year, I guess 2020 has been our nemesis. Now, a number of us, when we heard about COVID, went in various different directions to do our own particular research. But then there were also groups that got together and joined up and did a coordinated approach to research that made great strides in one particular direction. Because if we have multiple priorities and we're going in all different directions, we will not achieve anything in particular. So I'm going to highlight just one particular group, but I also want to reflect on the success, of course, of the Solidarity group, as well as the recovery group, which took a look at interventions and successfully brought us evidence in a very short time frame. But what I want to just raise here is the COVID Surge, Global Surge Collaborative, which has now involved at least 3 epidemiologic studies, and with a few in press and 2 already published, 88 countries, over 1,000 centers, and 52,000 patients already enrolled producing data. And this is also just to highlight that we have another upcoming study that is going to be global epidemiologic approach, and that's the COVID Surge Global Surge Week of October 2020. And hopefully you will be involved, because we'd love to have every country involved to get our evidence straight. So when we went as a group, coordinated globally, to take a look and actually inform our decisions around COVID in the perioperative period with a coordinated research approach, what we did first, and this is coordinated through University of Birmingham Global Surge COVID Surge Collaborative, what we did first was we took a look at that precipitous decline in elective surgery cancellations and quantified that, and found that there were 28.4 million surgeries which were canceled or deferred. Some of them were cancer surgeries. Overall, we estimated that there are about 72% of surgeries canceled. Now, this was based on our early knowledge in about March of the pandemic and involved modeling. But some of this has now actually been validated through country-level confirmations of that level of precipitous decline in access. So what we also did then was we took a look at the mortality and the perioperative pulmonary outcomes of patients who underwent surgery and also were diagnosed with COVID perioperatively. And we found that indeed, actually, their outcomes are worse than expected, several times increased risk of mortality and 51% postoperative complications, overall 24% mortality was found in the patients with a near to the operation diagnosis of COVID. So perhaps we were warranted in actually canceling these surgeries while we got ready for the pandemic, opened up our capacity, got the virus figured out, and came to understand how it does affect our patients so we can maximally protect both our patients and our healthcare workers. Next slide. But when I did some media interviews, radio interviews, as well as some newspaper interviews. And when I said this has never happened before, some of the patients called and said, how could you ever have let this happen? If surgeries around the world have never been canceled to this particular rate, how could you ever let this happen? And what I have had to say to our patients is that we hope to never let this happen again, because it has reverted our patients' access to safe, essential surgery. But we did need the time to prepare our staff, our stuff, our space, and our systems. Other questions that came from the public and from patients was, well, how come we're not actually getting access to surgery at the same rate as before? And to that I would say, we can't just flick a switch and turn on our systems, because we have this issue of bottlenecks in each of these areas of staff, stuff, space, and systems. And because of this, we're likely to get backlogs on backlogs. And because of this, we are also likely to have issues if we don't actually take a look at the weakest link in our chain and do that through a multi-sectoral approach. So now you might wonder whether or not we didn't see this coming. And I would have to say that indeed, we should have seen this coming. We have done some work in the past on behalf of the World Health Organization and with our colleagues in West Africa and in the Congo, and took a look at the risk, perioperative risk. And so when we took a look at Ebola, and we found that the perioperative risk of patients too, just like in COVID, was increased. What we also found was that when Ebola hit, it did also result in this precipitous decline of surgeries and access to surgeries. The other thing that we found was that 58% of surveyed hospitals, and we looked at 30 hospitals across West Africa, found that indeed 58% of hospitals reported that their healthcare workers had also been infected, and that the rates of infection were 10 times greater than in the community. The other thing that we found was that healthcare worker infection was 6 times greater if PPE was not accessible and routinely used. Next slide. So what we have done locally, we have locally as well as internationally used an intersectoral approach, because if we have these bottlenecks in terms of staff and stuff and space and systems of care, we're going to need to actually elevate ourselves beyond taking a look only at our linear surgical technical approaches. And we need to, yes, take a look at the evidence, and we've been doing quite well there, but we also need to bring in the issues of the economics, the sleepers, and the opportunity cost. And I'll come back to the sleepers in a moment, but basically what we need to do here, if we're gonna actually address our bottlenecks, is take a look not only insularly at our clinical outcomes, but also at the economic cost effectiveness, as well as the greater economic impact, as well as the sleepers, which is an acronym for the social, the legal, the ethical, environmental, political, and the entrepreneurial research and innovation opportunities, as well as the stickiness and sustainability factors. If we as a surgical anesthesia community are willing to go beyond our local socio-technical approaches, I think that we will be able to elevate to actually address our bottlenecks. And in terms of the last part, the opportunity cost, if we can start to talk about not only clinical outcomes and economic outcomes and sleepers, we also can talk about opportunity cost in terms of years of life lost, the types of things that our economists, as well as our patients care about and our societies care about, and what happens if we don't actually act. Next slide. So to end, what I would like to propose is that in order to get to this point of equitable surgical, obstetric, trauma, anesthesia care, we're going to need to go global. We're going to need to be very intersectoral if we're not going to make our bottlenecks worse. Because it is true, and as we found with our stockouts, both in low, middle, and high-income countries, as well as our bottlenecks with staff, as well as beds, as well as systems, we're only as strong as our weakest link. Thank you very much.
Thank you, Janet. That was amazing. Our next speaker is Dr. Susilo Chandra. Dr. Chandra is an anesthesiologist in Indonesia and serves on the board of directors for the Obstetric Anesthesia Society of Asia and Oceania and the World Society of Intravenous Anesthesia. He's currently the chair of the Asian Australian Regional section of the WFSA, and he's going to give a talk entitled Surgery, the Future is Here. So thank you very much, Dr. Chandra.
Thank you, Craig. Greetings from Jakarta, Indonesia, Asia. Ladies and gentlemen, thank you for the opportunity to present the idea about how we reach the tipping point in the midst of this COVID-19 pandemic. I would like to present about fast-track surgery. For most of us, this concept is not uncommon. Yet, I believe years ago, many research and publications have successfully mentioned the benefit of doing fast-track program, both for surgery or other medical procedures. During this pandemic, I've noticed more and more benefit on this concept, which could be applied in our daily practice. Next slide. I think it's fair to say that all of us have been significantly affected by this pandemic, but as clinicians, of course, we have to keep on moving forward. How to react toward this current situation. We spend months doing research, clinical trials, learning from cases. What do we learn so far? Next slide. How about containment in our hospital? We all can say that there is always a possibility of intra-hospital transmission. In intensive care and the respiratory ward, they have spatial ventilation unit. But the other mixed ward or waiting room for the patient, for the people awaiting swab result, might cause virus transmission, including to us, the health workers. The other thing that we have to consider is how about those non-COVID patients requiring our care, trauma cases, strokes, cardiac patient, and other infection disease. Also, what about our elective surgery patient? I believe many have postponed their scheduled surgery due to this pandemic. Still, we have to limit and minimize number of patients in the hospital to avoid unnecessary infection. Slide. Fast-track surgery is a multimodal approach to patient care using a combination of several evidence-based perioperative intervention to expedite recovery after surgery. It is an extension to the critical pathway in the integrated modalities in surgery, anesthesia, and nutrition as well. Enforces early mobilization and feeding, and emphasize reduction of the surgical stress response. It entails the great partnership between a surgeon and anesthesiologist with several other specialists to form a multidisciplinary team, which may then engage in the patient care. The practice of fast-track surgery has yielded excellent results, and there has been a significant reduction in hospital stay without a rise of complication or readmission. The effective implementation begins with the formulation of protocols, carrying out its intervention, and gathering outcome data. The care of patient is divided into 3 phases. First, before, during, and after surgery. Next slide. Health facility may become overwhelmed and have insufficient capacity to provide adequate treatment to those most in need of care, especially during this pandemic. Telehealth is a safe and effective way to assess suspected cases and guide the patient diagnosis and treatment, minimizing the risk of disease transmission. It is very convenient for most patients as it allows non-emergent patients to remain at home, including preoperative patients. All preoperative consultation might be conducted through teleconsultation. Discharge from post-op patient might be followed by the same technique to maintain continuity of care. Instruction for prescription as well as at-home physiotherapy might be beneficial through teleconsultation. I've seen more and more drive-to labs during this pandemic. Drive-up laboratory service for both of COVID and non-COVID medical testing to help patients remain socially distanced. Patients with a doctor referral for lab services such as cholesterol check, blood panel for pre-op surgery, liver enzyme test, newborn screening, and other necessary tests will be able to have complete lab blood draw without leaving their vehicle. The drive-through laboratory aims to reduce anxiety for the patient who need to come to the hospital while providing a convenient option for lab services. Next slide. Enhanced recovery after surgery protocols are multimodal preoperative care pathway designed to achieve early recovery after surgery procedure by maintaining preoperative organ function and reducing the profound stress response following surgery. The key element of ERA's protocol, including preoperative counseling, optimization of nutrition, standardized analgesic and anesthetic regimen, and early mobilization. Slide. So what are the outcomes? Fast-track surgical programs involve implementation of packages of multidisciplinary evidence-based intervention, which have the potential for significant reduction in post-operative complication and the length of hospital stay. Higher patient turnover might be beneficial as they allow more physical distancing inside the hospital to minimize intraoperative intra-hospital transmission, as well as higher number of patients. It does improve health economics outcome as well. Next slide. So for the take-home message, fast-track surgery is beneficial to reduce intra-hospital transmission. Telehealth and drive-through labs may be aid this program. Successful ERA's implementation is beneficial to improve quality of care. I think for that, I should say thank you very much for your kind attention.
That was awesome. Thank you, Susilo. Our next speaker is going to be Dr. Erlinda Oracion. She is a pediatric anesthesiologist in the Philippines, and she's a member of the Safety and Quality of Practice Committee of the WFSA. The title of her talk today is going to be Tipping the Point with Creative and Innovative Leadership. So thank you very much.
Hello, everyone. First of all, thank you to the G4 Alliance for this opportunity to share and learn with esteemed colleagues. Allow me to honor everyone in this panel for their presence and their pearls of wisdom. Anesthesia, the gift of oblivion and the mystery of unconsciousness. The book by Kate Cole Adams that takes the reader on the lyrical journey through the vital question of what it means to be human. When facing an unknown challenge like this pandemic, it is possible only to do too much or not enough. More than ever, the anesthesiologist has risen to be the silent glue and backbone of clinical medicine and the critical care physician of the operating room. For anesthesia, this is our first modern pilot goes down with the plane safety issue. While we might be stretching that metaphor too far, it does help to frame our collective anxiety. It reveals both the shared hazard of a contagion and also the foundation for the anxiety that many feel. No issue appears more emotive than the challenge of personal protective equipment. To outsiders, the emotion and fear may seem excessive, but for healthcare workers, this fear is protective. So we learned that stockpiles of supplies and inventories, emergency reserve backup, was really comforting and satisfying. So the other personally emotive issue is the facilitation of tracheal intubation. We learned that every second counts. We need to breathe everything. We are afraid to contaminate ourselves. And although stressed and rushed, we must remember that we are an important vector of spreading the virus. How about the challenge of algorithms? We needed to design an intubation protocol wherein we had to seal the mask, have medications, clamp the tube, and have an emergency anesthesia plan. We had to have good timing when we intubate. You are next to a nuclear reactor when we don and doff. So you have to go in confident and fast and be successful on the first try. We learned that training in donning and doffing is essential. Time management is critical. Do not rush this. Rushing in to resuscitate deteriorating patients will compromise our personal protection and result in tragedy. Safety in the OR was also a challenge. We learned that we needed to reinforce and enhance infection control practices like double gloving and learning to wipe down and disinfect everything we use. We had to create teams to vet literature, upgrade ORs, create OR protocols, and educate our colleagues. We learned collaboration with the community who designed and donated aerosol boxes, frames, and finally, plastic biodegradable drapes. We had our checklists as infographics on all our walls, and we had a checker to spot or a safety officer whenever we wanted to don or doff. So managing resources was difficult, not only in terms of PPE, but also in staffing and manpower. We had to break down our silos and work with each other. We identified point persons to vet all cases that were booked. We managed fear and anxiety of the healthcare workers. We helped them go through a COVID positive time in their lives. And the challenge for our non-COVID patients was certainly to avoid the ED and office visits. As mentioned earlier, we used telemedicine, we used primary care clinics, laboratory on wheels, and home vaccination visits were encouraged. But the greatest challenge was continuing medical education for all clinicians and trainees. We had to take care of them through education and information. Trainers and faculty had to adopt to new platforms of hybrid teaching and blended learning through simulations, Zoom meetings for debriefings, and social media chat groups for more information. How then did we tip that point with creative and innovative leadership? That tipping point is safety for all, to keep everyone safe in our care, and that time is now. We have to learn it all now. We need to build a great team and a system to keep track of our work because we need to address the circumstances of a fluid and uncertain era. We learn on the fly by getting feedback from our frontliners. We need to adopt new lessons and neglect routine care so that we could improve. But most of all, we do not lose sight of where we want to go to keep safe for everyone and to keep everybody safe as well. So we learn, we watch, we work hard, we ask for help. Most of all, we have to share with other people what we have learned. What about our community? Telemedicine is a digital innovation that has been with us for the longest time, and it was only COVID-19 that pushed people to accept this faster because of fear. So in terms of community concerns, pre-op assessments and post-op follow-ups were done through teleconsults, targeted testing to protect not only healthcare workers, but the community as well. The incredible upheaval of our healthcare system and our society due to this pandemic can also be viewed as an opportunity for much needed change, improvement, and innovation. But we must remember that people are our most valuable resource. We help manage their fear, keep them informed all the time. We need to keep them protected and comfortable, not only in the operating room, but outside as well, especially the vulnerable populations. everybody has the capacity to lead. And we have to be present, listen, and connect all the time in order to do this. Communicate, 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 because this is certainly the cycle that leads us to improve. Above all, we honor everybody. We honor and recognize all healthcare workers, but we do need to honor and recognize all the anesthesiologists who have stepped up to be better at being the glue and the backbone of clinical medicine, and to be that critical care physician, not only in the operating room, but outside the operating room. We must take care of ourselves, including getting enough sleep, exercise, nutrition, and managing stress. Emotional health is real. Mental health is real. We need to protect our family and our friends, and we have to support the community. When times are tough, we dare to be tougher. The strongest people are really not the ones who show strength in front of others, but those others know nothing about. Remember that one day we will look back to this time and realize how much it has changed everything. Simple things like a handshake or sitting with a colleague for lunch will hopefully never be taken for granted again. Thank you very much.
Thank you very much, Erlinda. That was great. I just want to say we're running a little short on our scheduled time, and we have two more speakers that are going to give great talks. I have checked with the organizers, and I guess since we're a webinar format, one of the advantages is we can stick around for a little bit and make sure that people's questions get answered. There's already a few questions on the Q&A board, and so I don't know if all the panelists can stick around, but for as many people as can, we will maybe stay for another 15 minutes or so after the conclusion to try to get people's questions answered. Okay. So our next speaker is Rick Henker. He's a practicing CRNA at the University of Pittsburgh in Pittsburgh, Pennsylvania, here in the USA. And he has a long list of programs he has been instrumental in developing. He's coordinated nurse anesthesia development and education for health volunteers overseas in Belize, Cambodia, Laos, and Bhutan. And he is currently the AANA representative to the G4 Alliance. And Rick is going to give us a talk entitled Building the Anesthesia Workforce, Lao People's Democratic Republic.
Hey, thanks so much, Craig. A pleasure to present to this group today on a topic that I absolutely love. So if you could go to the next slide, Dan. And next slide, Dan, go ahead and we'll skip through that. So I've put some things in here about Lao, but the piece that people should know is that Lao is the most bombed country in the world from the Vietnam War. The Pathet Lao were in a civil war with CIA-supported forces in Lao, and the Hmong were actually trained by the US to fight in that war, and it devastated the country. And we still have cluster bombs, live ordnance that are present in Lao. I'm going to skip the other piece. You can take a look at those slides. It just gives you a little background. If I could go to the next slide, Dan. So the number of surgeries per year in Laos, 652 per 100,000. So in Sweden, it's 15,000 per 100,000. So you know that there's not much surgery that's done there. The important piece you can see, Luang Prabang is the 4th largest city. And the place that I work at, Lao Friends Hospital for Children, is on the grounds of Luang Prabang Provincial Hospital. And they only have 6 surgeons in the 4th largest city in Laos, 1 anesthesiologist, and most of the anesthesia there is provided by medical assistants. There are limited, essentially there's no oncology services. If you have cancer, you have to go to Thailand or China in order to receive care. Next picture. This just gives you under age 5 mortality, and this is districts in Luang Prabang province. If you compare this to, say, a country such as Vietnam, you can see in one of the districts, Phang Xe in Luang Prabang province, it's 107, and it compares with Vietnam where it's 21 per 1,000. Next slide, Dan. So the anesthesia workforce in Laos, and WFSA has published some things in terms of workforce, as all of you I'm sure know, and that is that in Laos it's reported that we have 60 anesthesiologists, and you compare that to low resource settings such as Cambodia, and it's like, wow, we're even dramatically lower than Cambodia. Those that provide anesthesia, 70% of the anesthesia care is provided by nurses, medical assistants, general physicians, and typically they don't have much anesthesia education. So next slide, Dan. So what the group that I worked with, and Craig actually helped with this program initially in terms of, you know, discussing the setup and how we were going to do this. But Lao Friends Hospital for Children opened in 2015, and we went ahead and started a nurse anesthesia education program to educate some of the nurses there to provide anesthesia services. So we opened the operating theater in 2016, and our program was taught by the health volunteers overseas, volunteers, nurses, physicians, nurse anesthetists, and physicians. And we actually have recognition from Jackie Rawls Group, the International Federation of Nurse Anesthetists. So the practice there is ultrasound is incredibly important because we try to do as many blocks as possible because of the safety and the benefits of doing our anesthesia care. Next slide, Dan. So how have we been able to do this? One of the things that we've developed in Southeast Asia is kind of a network in terms of the education. And one of the keys to this has been Siri Raj Hospital, Department of Anesthesiology. And they've provided didactic and clinical education for many of the trainees that we've had in Bhutan, Laos, Cambodia. And they have a simulation center. So if you look at this picture off to the right, Dr. Tashawan has been key at Siri Raj in terms of coordinating much of the education. And we have, this is when we had a Bhutan group along with some of the PIT students that I work with, and Dr. Tashawan and Gap, who's a nurse anesthetist, in terms of teaching at that simulation center. Siem Reap, Cambodia Anchor Hospital for Children has also ended up being an education center, not only for nurses and physicians in Cambodia, but we had our nurse anesthetist from Lao Friends Hospital for Children go to Siem Reap for anywhere from 5 to 7 months to learn how to do cases. Of course, HVO and then the Winter Institute for Simulation Education and Research and University of Pittsburgh have provided resources to go ahead and teach. And actually, we've had nurse anesthetists from Cambodia and Laos come to Pittsburgh for some of their clinical education, and also to provide lectures. Next slide. So what are we doing in Laos? So first, National Surgical Plan. And the picture shows Dr. Tracheal and Dr. Sivasai, who are the Chief of Anesthesia and Chief Surgeon at the Mahasat National Referral Hospital in Vientiane. And we brought them to Manila. They presented about their surgical plan, and they are realizing how important it is to have a surgical plan and what we need to do. Now, we've worked more with Dr. Tracheal with anesthesia, and we're starting to work on grants. The downside of the pandemic, it's prevented many of us going into Laos and working with these groups. The upside is we've had time to work on grants. So we are working on identifying providers, and then we submitted a grant to go ahead and provide in-service education to that 70% of providers that are providing anesthesia. And we'd like to go ahead and do some programs. I know we've talked to WFSA about doing SAFE programs also in Laos. We want to support the residency program. So we've talked about volunteers coming in and helping teach in that residency program. They only have 8 residents per year, so we realize that we have to work on other ways to enhance this workforce. Another piece is reopening the nurse anesthesia program. 2014, they had 2 cohorts of students that went through a nurse anesthesia program. So we've been working with the dean at the University of Health Sciences in Vientiane to go ahead and work on developing that program. And then evaluation of care. So we've been working, our team has been working with World Health Organization, JICA, Ministry of Health, and coming up with indicators that would be part of the Ministry of Health in terms of what they would evaluate. And we're also, we have a really good shot. It looks like we're in phase 2 of a grant to look at quality improvement and process improvement, and using Lao Friends Hospital for Children kind of as a hub for teaching those things in Northern Lao. Next slide, Dan. So what are we doing in Laos? One, we have to look at we have to do a needs assessment. What is the workforce? Where do we start? Then look at their policies and work with their policies and see what needs to be improved. And then look at what they have in terms of sustainable systems. So we're working with many of the people there and the current infrastructure, seeing how we can go ahead and improve or build that anesthesia workforce. And then making sure that we have a piece on evaluating, so indicators in terms of care, and then also looking at, evaluating the number of providers, the quality of providers, and where they are at the district and provincial hospitals within Lao. Thank you very much. Just a pleasure to be part of this group.
Rick, that's fantastic. Really just amazing work you guys are doing in Southeast Asia. Our last speaker is Jackie Rolls. She's a CRNA specializing in pain management and has previously served as the U.S. representative to the International Federation of Nurse Anesthetists. She's a fellow in the American Academy of Nursing, which I know is a huge deal because I happen to marry a nurse in academics. And she's also a fellow in the American Academy of Pain Management. She's a former president of the AANA and currently serves as the IFNA representative to the G4 Alliance. And the title of her talk today is Nurse Anesthesia Efforts to Affect the Tipping Point of Increased Access to Surgical Care.
Thank you very much, and thank you for allowing me this opportunity to address everyone today. Dan, we can go to the next. Oh, perfect. Just a brief introduction to the International Federation of Nurse Anesthetists for those that don't know us. We were chartered in 1989 with 11 countries, and we currently enjoy 43 member countries. We can go to the next slide. All of our efforts really are aimed at the provision of excellent anesthesia care to our public. We want to unite nurse anesthetists globally, share information and advancements, assist with requests that we get for information on truly what's the role of a nurse anesthetist, what's the scope of practice internationally. We've developed and shared standards of education and practice. We also have model curriculum for nurse anesthesia educational programs at the certificate, bachelor's, and master's levels. We've shared that with WFSA as we're trying to work together on educational programs. We provide accreditation of non-physician educational programs through a program called Anesthesia Program Approval Process. So it is a global accreditation. And we collaborate with other organizations in order to advance anesthesia and safe surgery agenda. Next slide. Our key collaborative organizations are the International Council of Nurses, the WFSA, and with WHO, with the Global Initiative for Essential and Emergency Surgical Care, G4 Alliance, and Mercy Ships. And we truly come from a viewpoint of we are stronger together. So how do we affect the anesthesia manpower tipping point? We know that there is a huge need for anesthesia providers, and of course that affects the ability to offer surgical services. So by working together with all of our anesthesia colleagues and organizations, we need to make sure that we have recognition of all providers, respect for what we do. Teamwork is huge. And then optimal training of all anesthesia providers. If anyone's going to be given an anesthetic, they obviously need to have good training. It's all about patient care. We want to ensure that all anesthesia team members are able to participate to the highest level of their education, training, skills, and competencies, because that is the way that we can optimize the workforce and therefore help with manpower shortages. What are we doing specifically right now that are big projects? We're in the midst of editing, or I am, along with two other editors, a 30-year history book of IFNA. We have 42 of our 43 country histories, and it details and chronicles how nurses, and in 2 of our countries are technicians, how we have impacted the availability of surgical care and services. We talk about working with our anesthesia colleagues, what the education's been, but it's important to document our history so that we can bring recognition to the value and the services offered. We are also currently working with ICN on a task force that's developing global guidelines for nurse anesthesia. So that's to define the role, to look at it as an advanced practice role, define what education should be, minimum levels, and that's targeted to be completed this December, as will our history book. So those are 2 big pieces we can share with everyone to talk about nurse anesthesia. Next slide. And I want to say, let's all work together to move past this tipping point. That's the only way we're going to get there. And we all realize that. Those of us here are all committed to work together, or we wouldn't be on this call. Next slide. I want to just say thank you to the G4 Alliance for the opportunity to present. I've served as treasurer for 3 years of the G4. It's a great organization. And I think everybody here believes in the mission and vision and the work of G4. Again, one more slide, I think. It's just a thank you. Oh, questions and discussion. I had a thank you slide at the end, but that's okay. So quickly, that's my introduction and my statement of how IFNA wants to work together with everyone to get this accomplished.
Thank you so much, Jackie. And thanks to all the speakers. You know, I always feel like the sign of a good talk is when you're left wanting more. I can honestly say for each one of the presenters today, I felt like I could have listened to another hour of information being presented about the various topics. So thank you so much. Really wonderful talks. The webinar was scheduled to go till 9:30. We are at about 9:30, but I want to make sure that people have an opportunity for discussion. So the organizers have let us know we can stick around for a few minutes. So how about we say another 15 minutes of discussion, and at that point we'll close it out. But I want to give people an opportunity to ask questions. So why don't we move on to the questions? There are a few on the question board. And Sheena, maybe you might be uniquely positioned to answer most of these because they have to do with the COVID response in Nigeria. So from Dr. Sharma, my good friend, there are a couple of questions. So one is, what was the PPE situation in Lagos and how is it now? And the other question is from him is, any experience in prone ventilation in Lagos?
Thank you very much, Craig. And I want to thank Dr. Sharma too for this question. I was expecting that I probably will be called upon at one time or the other to answer some questions on my presentation. The first question is the state of the PPE in Lagos. I must say that earlier on in the response, we had a rather apparent shortage of PPEs, which is not undue to the fact that there was lockdown, there was restriction of international travels, and that affected importation of PPEs. However, with time, in Lagos, we were able to introduce the strategy of rational and appropriate use of PPEs. And by the time we've done about 1 or 2 months or 3 months of response, we had local companies producing the PPEs as well. So to a large extent, we presently don't have acute shortage of PPEs in Lagos. Also is the fact that we have a good logistic pillar in place, and that has affected the supply chain of most of the consumables and PPEs. And mainly the strategy of rational and appropriate use of PPEs has impacted positively on our PPE in Lagos, this in Lagos. Now, with respect to the second question, which is the experience with prone ventilation in Lagos. Yes, in the early days of the pandemic, as was done in China, in the US, and Spain, a lot of the patients were put on ventilators. We did the same thing. But further down the line, when we got to know the pathophysiology of the COVID-19 effect on the respiratory system itself, the strategy changed to non-invasive ventilation of our patients. That this was around middle of May or thereabout. And that has impacted very well positively on our patients. And we actually now started introducing the prone position for all our patients. All those we put on oxygen therapy, we put them on prone, and for about 6 days or thereabout, depending on the length of stay they are with us in the ICU. And that has also, the outcome has improved tremendously. Putting on prone position, in addition to having best physiotherapists, respiratory physicians, as the case may, technicians as the case may be, but mainly in our ICU, COVID-19 ICU in Yaba, we have physiotherapists. So combination of this has actually allowed us to have a very good positive outcome in our patients managed in the ICU. Most of these patients, as we are aware, also come with comorbidities anyway. And prone position, I must say, has helped us a lot in achieving a good result. Thank you. Thank you,
Sheena. We have another question here that gets to one of the things I think is interesting. It's asking about, we certainly all agree that capacity building, education, technology, innovation are all important, but what strategies are put in place to reduce the disparities between urban and rural areas in terms of quality and quantity of training and accessibility to safe care? So I will throw that out to the panel, whoever wants to take that.
Well, since maybe I should just say one or two things on that. Yes, for us in Nigeria, we have tertiary institutions, secondary institutions, and primary healthcare facilities that are strewn all over the country. And recently, as I mentioned in my presentation, the Federal Ministry of Health actually conducted a train-the-trainers course for relevant personnel, healthcare personnel, including case management. One of the things which is done is incentives, giving incentives for those hospitals, facilities in the hinterland, and weighted on the balance. There are more incentives for healthcare practitioners working in the hinterlands than those in the urban areas. And the federal government and some state governments have gone a step higher to actually make sure that they put in place equipments, schools for relations or children of healthcare practitioners. All these are strategies geared to making sure that skilled personnel do come to the hinterland other than just staying in the urban centers. That's one of the strategies that has been done in Nigeria.
This is Rick. One of the programs that we had, and I taught in this program in Cambodia, but we're trying to implement it in Laos. And that is, it was a 6-month program, and we'd take existing anesthesia providers in the rural areas for 2 weeks. They'd go to the National Pediatric Hospital in Phnom Penh for 2 weeks and engage in clinical and didactic, and it's a cohort of 10 individuals. They'd go back to their homes for 2 weeks and practice there, and then every 2 weeks they would alternate. So we're trying to fund the same type of program where we have individuals from the rural areas where we bring them in and do education and then send them back.
That's awesome. Thanks, guys. Yeah, I think the rural urban divide is a problem that I think as we get more granular data becomes more and more prominent. I mean, the Lancet Commission, put out the idea that, you need 20 SAO providers per 100,000 people. And when you look at country level data, there's a lot of countries that check that box, but we've done some work at the Program of Global Surgery looking at even the United States trying to hit this number, but on a much more granular level. And there are areas of the United States that barely check that box. So I think that, and they tend to be more rural, as one would expect. So I think that's going to be a real direction of where we can invest efforts. So thanks for that. So we have another question from my friend, Dr. Matt Kynes. Thank you, Matt. He says it's regarding sustaining investments in anesthesia and critical care during COVID, but over the long term. And he talks about there are other examples of heavy financial investment that have not really translated to sustainable change. So how can our global health community push for sustained investment over time as COVID fades? And what would you prioritize? So I think that's a great question. And I think it gets more to policy side of things. So, here we are at the UNGA trying to affect policymakers. So what do people think about that? How do we invest better to make sustained change?
Perhaps I could just add a couple of comments around that, because my presentation started to focus a little bit on how can we use the language of policymakers across the sectors in order to be more clear about what we're trying to do. So in one of the terms that I used is opportunity cost as well as sleepers. And so I think if we're willing to go beyond just talking amongst ourselves as surgeons, anesthesiologists, and researchers, and only about the clinical outcomes, but also to be able to translate things into years of life lost or numbers of patients lost, but years of life lost and productivity lost resonates well with many different sectors. And if we're able to have such a coordinated approach to distilling what we can do in SOTA in order to improve years of life lost, I think that we'll actually be able to make some tangible and sustainable changes. If we don't, we become just one of the many priorities that have come up because of COVID. And COVID has raised every single priority, and our governments and policymakers cannot go in all directions at once. We will not achieve anything. So that's the point, is to have the language of policymakers, and that's bringing all of those sectors together as well as all of those lenses in order to translate to number of years of life lost if we don't act versus if we do. And we've been doing some research on this in a few countries, not only to take a look at COVID impact on years of life lost, and it's millions in, for example, the UK alone and the US alone, but what about those collateral effects, even in terms of dropping off in our access to safe surgery? And this has affected high and middle and low income countries. But the disproportion in terms of inequities driven in middle and low income countries is astounding. And we're all so interconnected in terms of stockouts and availability of PPE and drugs for the critical care setting and the ICU. And if we don't take a coordinated global approach, we're actually going to make our situation and our bottlenecks worse. And so I think it's about bringing it all together so that our economists, our education, our biosecurity, pandemic responsiveness can actually associate and understand and resonate with us as well as society. So I think that's part of the key right there. So far, we've been very much insular and talking about within our own circles of professions across disciplines, but I think we need to go bigger and also global.
May I participate with this also about talking about this question? It's maybe I'll tell you a little of our experience in our region. We have seen anesthesia societies and critical care societies involved in these all these measurements beyond going about this crisis, COVID-19 crisis. And it's the engage and the involvement of these societies that may bring something different also. So we're trying to be sitting at the table with our government authorities, but not for deciding the menu. And it's a very good move. We've been experiencing it here, at least in my country, the Honduras, and trying to make policies and trying to influence in what the policies that coming along with this crisis. So the impact of or the liaison with the societies and the government, it's a very good point for a long-term impact in our society and our region. Thank you.
I'd like to participate as well in that question because as both of my esteemed colleagues have said, it has really made an impact when physicians, when all these medical societies come together and speak with the government agencies in order to be able to have what we need to do to set it forward. Because like in the Philippines, there was actually a move by healthcare workers to really put the country, the national capital region, in a lockdown again so that we could step back and just look at what we wanted to do, how we want to move forward, and in order to preserve our healthcare workers as well. So it's really centralizing. The way we would do it in safety is to centralize everything, standardize. That has become an issue with the local governments in our country because our health budget has been devolved. So it has come down to the local government units. Unlike if it were a unified, as you said, Janet, it should be a global thing so that we can all work together. And I think that we have broken down silos. So maybe it's about time that we keep these silos down and start working together. Thank you.
That was great. Thank you very much for everyone's thoughts. Maybe we'll go another couple of minutes here. And as not exactly the same question, I'm always struck that in the sort of global surgery community, one of the policy things that people seem to really lock onto are the idea of NSOPs and National Surgical Obstetric and Anesthesia Plans. Which I think can be really important guiding pieces of legislation. I also worry that in countries, who are trying to keep up with each other, that simply putting a piece of legislation in place or a plan in place doesn't necessarily guarantee that that plan is going to do anything. And so, I'm curious from the panel, for those of you who either work in countries that have existing NSOPs or live in countries that have existing NSOPs and work there, or visit and do work in countries that have NSOPs, how do you see that NSOP affecting change in the delivery of safe anesthesia? And how would you suggest that we assess and measure NSOPs so we can give feedback to the policymakers so that we can make those plans really living plans to adapt to whatever that country's situation is?
I see Yannike has something to say about this. She has her hands up. So Yannike?
No, just one comment, not to the whole, all the questions you have, but I think it's very important that we do develop NSOPs and get the politicians together with us, because we can do whatever we want, but unless it's covered from the top and you get a top in buy-in for that. So, but we must influence them to take responsibility. And it's the same thing with checklists and all of what we are doing. It's the implementation thing. The work is not done by having an NSOP, but nothing will happen unless we are driving it. So we have to lobby with the politicians, follow up, work on the ground and so on. That was just one thought about that.
Perhaps Zipporah wants to say something about experience in Kenya influencing the government during the COVID period. Zipporah?
Thank you, Bisola. I would say that one of the things that have come out of this COVID thing is that the government has now realized that it is important to listen to the people who are dealing with the issues. It is important to listen to the caregivers. And I think this is an opportunity that we can use to further put our case forward so that then the gains that have been made can be taken forward, that the pace that has been set in terms of equipping the new critical care units, getting oxygen into places that didn't have, training people that can provide care in those areas will translate in the long term to improved care for the populace of this country. Now that we have the government here, they tend to have maybe so many competing issues that you really have to have good people doing advocacy, like what G4 Alliance does. We really need to learn that so that then the gains that we have made can be sustained. And like Yannick says, we really need to be on the table to make sure that when decisions are made about healthcare, about universal health coverage, about all the things that our politicians have accepted on the global forum at WHA, at World Bank in terms of finances, budgets are followed through. So I think it is a good opportunity that now we have their ear, that we have to find a way of keeping that ear tuned to what our needs as anesthesia and surgical systems are.
Thank you, Zipporah. There's one thing that was said in one of the questions. Some panelists mentioned attack and harm towards healthcare workers. What were the roots of these actions and what actions have been taken to protect healthcare workers? And we have heard of staff stuff, space and system. And then someone said, think of the self. So can we talk about that as well as deal with the factors that make quality of anesthesia difficult for clinicians on the ground? Can we take that, please?
Yeah, thank you very much, Bisola, for coming up and joining us this side of the divide. I would only make 2 comments. The first one is still on the NSWAP business, which Craig introduced earlier on. With us in Nigeria, we have the NSWAPs in place. And I want to say this has helped us a lot in collaborating with our other healthcare providers, the surgeons, the obstetricians, and it has actually impacted positively on the clinical outcome of our patients. Now, we don't have the surgeons being on their own to arrange for cases and having anesthetists come in and whatever. But now, because of the buy-in of all the 4 critical specialties involved, we now have a sort of synergy between us all, and that has impact. We have case clinics, case management meetings, and this they are impacted positively for the outcome on the part of the patients. Also, in Nigeria, we have the buy-in of the federal government in this, and this has actually helped us a lot. And permit me to say that Dr. Ogunbiyi has been in the forefront of this NSWAP's business, and we have actually achieved a lot in the last 1 year. And I want to suggest that there must be a proper evaluation and monitoring of the outcomes of the NSWAPs. by all nations that have it as a form of strategy. There has to, the WFSA or whatever body should put in place an E&M to make sure that these things are carried out as stated in the plans. That's my comment for the NSWAPs. Now, with respect to the quality of anesthesia that is being given out by healthcare providers in the anesthesia section, we can actually improve this by, one, being relevant in the scheme of affairs of your society and the society at large, collaborating with others, attending conferences, seminars, webinars such as this, and even encouraging all the skilled specialists not to depend just on their certificates, but also to improve on the basic certificates as much as possible. I think with this, we can increase the quality of care that we offer to our patients. I mean, I'm sure I won't be the only one that will be surprised if we still have some countries or some individuals that think that pentone is the only induction agent available in theaters. Thank you.
Awesome. Thanks, guys. Thanks, everybody. That was really fantastic and inspiring, all the talks and the thoughtful discussion. So I think, I still see there's 180 people that are on nearly 30 minutes after we were supposed to be finished. So I think that's a testament to how important and interesting this is to people. There's so much good work going on, and I really hope this has made a strong impression on the policy influencers and makers who are listening to this. If we want to achieve real universal health care and coverage, it cannot be done without supporting functional surgical systems. And clearly a huge component of surgical systems is the anesthetic care of surgical patients. There's little surgical care that can be delivered without our involvement. And anesthesia providers are uniquely positioned to support the entire health system in times of acute healthcare crisis like the current pandemic. So I want to thank all the speakers who gave wonderful talks. I would like to thank the G4 Alliance for putting this on. In particular, I'd like to thank my colleagues on the organizing committee. Bisola has been amazing. We've never been able to get this together without her drive and assistance. As many of you know, Bisola is the secretary of the permanent council of the G4 Alliance, and also happens to be the president of the Nigerian Society of Anesthetists. So we're very fortunate to be able to work with her. We also had the indispensable assistance of Michaela Stanky and Kashmira Shala from the program in Global Surgery and Social Change. And Michaela is a medical student, so hopefully we're convincing her to go into a career in anesthesiology. And Kashmira recently finished her anesthesia training and now is as an attending anesthesiologist at Beth Israel Deaconess Hospital in Boston. Thank you very much for the interpreter services that were provided. The webinar will be available on the G4 website, which the address for that is www.theg4alliance.org. It'll be recorded and there'll be translations in both French and Spanish as well as English. So, like I said, I want to thank the G4. I want to thank the Global Initiative for Children's Surgery, as well as the Program for Global Surgery. And then there are numerous partners, as you can see from this slide. Clearly, the volume of support we have received is tremendous. And it's really so inspiring to see the global surgery community come together to continue to push the message of the necessity of investing in surgical systems from the standpoints of equity, humanitarianism, and economies. So that concludes the webinar. Thank you very much for your attention and interest, and everybody stay safe. Thank you very much.
Thank you.
So Dan, we're on 12:30.
Yes, Rick, we'll talk to you at 12:30 Eastern time.
Okay. Craig, thanks for putting this together, and all the staff at Program for Global Surgery and Social Change, and along with Natalie and Dan. Wonderful. Glad to be a part of this. So thank you so much.
Yes, you guys gave amazing talks. Thank you so much. This was wonderful.
Thanks to all of you.
I want to thank Craig particularly because the way he handled us was wonderful. And I'm sure all the present, all of us were within the time limits of 6, 7, or 8 minutes. And that's
10 minutes.
awesome. And to Dan particularly, before we started the program, he had told us when to give him prompts and so on and so forth. And for me, that's awesome. You did very well. Thank you very much, Dan.
Thank you, Sheena. Thank you very much.
Yes.
Yes, thank you.
And I must say thank you to everyone. Thank you to all our speakers. I know you're speaking from all parts, different parts of the world, and we're happy to have you participate. Those who have signed in even late at night from the Philippines, from Jakarta, thank you very much. Early morning in Ontario, thank you very much for joining. From Canada, thank you very much for the ambassador of Tanzania to Canada, Dr. Ulisibisia, difficult name, Mpoki. So thank you very much, really. And the president of the WFSA, we appreciate you all. Thank you. Craig, well done. Dan, really grateful for this fantastic work you've done. Beautiful ladies from the PSCCG, please, I want to say thank you. I appreciate you all. Thanks.
Bye-bye. Yes, thank you.
Somebody's asking when is the next webinar?
We still have 90 attendees listening. If any of you would like to say hello, just raise your hand and I'll connect you with the panelists. You're welcome to join. Just click raise your hand.
This is really just the beginning for the G4 Alliance, because we want to get more people, especially anesthesiologists, anesthesia providers involved, you know, in this kind of discussion. We need to talk together and, you know, be creative in our solutions instead of just crying help. We want to make an impact globally. So thanks. You're all invited to join the G4.
Yes. Michael, you're there.
Good morning, Dan. How are you?
Great. You got up very early there in Utah. Thank you for joining us early.
You bet. Well, you know, 6 a.m. is not that early. We've done some 5 a.m. meetings.
Yep.
So, I am thrilled. Listen, I had a wonderful dinner with Stephen Hunch, who's up in Park City.
Great.
And, we talked about the need to jump on fundraising more than ever before. With this kind of interest from around the world, it points to really a push that needs to be made at this point for world leaders to provide us with the funding that we need to carry out all these initiatives being done on a global basis.
And panelist Michael, who's speaking, leads Mobile Surgery International, which is up in the upper left corner of the screen right now. And he's joining us from Utah, a G4 member.
So we need to find, Dan, a time to have our next meeting once we get through all of the UNGA meetings.
Absolutely. Looking forward to it. Looking forward to it.
Great. Thanks, Dan.
Okay, everyone.
I also want to say about the number crunching, Janet Martins.
Oh,
she is
terrific.
our quantitative researcher. And thank you for taking this global. We're looking forward to more work, more research done. And hopefully you're going to be including Sub-Saharan Africa. Janet?
Yes, Sub-Saharan Africa is a big part of the heart of the world, isn't it? Big part of my heart too. Yes, I really am very passionate about the fact that we have this COVID-19 crisis, which elevates the need for safe, accessible surgery and anesthesia and perioperative care, right? So with crisis comes opportunity, and I'm putting a plea out there for us to join up globally to act on this, because it's very difficult if we all try to have our own voices and our own priorities. You know, I've said it a few times today, but if we join up those priorities and those efforts to first work on the highest priority bottlenecks, because if we don't, each of us going in our own direction will make the bottlenecks worse for the most vulnerable first. And we need that global lens in order not to be inducing those worsened bottlenecks and those worsened stockouts and PPE and drug shortages around the world, which affects our most vulnerable colleagues first. And having that language that talks about years of life lost and what happens if we don't do something really has resonated well with policymakers in our attempts to do so far.
Yes, can I also say I appreciate the work of Bruce Picard in South Africa, leading ASOS, another amazing qualitative researcher, and I think he's in the crowd somewhere. So Bruce, if you're there, we would like you to raise up your hands and say something to us. Bruce, are you there?
I don't see Bruce, at least in the names of the attendees left. There's still 73 attendees left, but I don't see Bruce's name there now.
I echo that. Bruce's leadership for the ASOS initiatives has been earth-shattering and has absolutely changed the game for evidence informing policy in Africa perioperatively. Unbelievable work, and it just keeps building in its momentum. So just so happy to give kudos to Bruce and the whole team. So many countries across Africa have contributed to that.
Yeah, I would echo that. I think Bruce has been one of the real drivers over the last several years in moving the research questions to more, not so much simply capacity assessments, but really asking the questions of how patients do, where are the problems, and what can we do about that. So it's invaluable, I think.
And the value that comes from having cross-country analyses so that you can, with sufficient power, but across a number of settings so that you can actually do contextual analyses. Again, in 7 minutes, didn't have time to dig into that, but that is unbelievable. And that's why, again, we need a joined up global approach. Otherwise, we have no hope of having contextually relevant analyses of adequate power. So you'll hear more about that too, I think, in upcoming months and years as we progress towards safe access around the world.
I'm sure Dan was really excited to hear about the checklist, Dan.
Absolutely.
Dan, yeah. So Dan is used to using the checklist in his career as a pilot in the aviation industry. So maybe Dan wants to say how the checklist has helped in aviation, and then look at how we can benefit also in anesthesia, although Yannick has said quite a lot about the checklist in anesthesia, especially with COVID. Dan, over to you.
Well, the analogy, the metaphor used was excellent in that there are truly two types of checklists. There's normal procedures and emergency procedures, and to have checklists for both of those and be ready to pull those out and use them. It's also interesting to note in aviation, there's a couple different ways that people use checklists. Some people prefer to go through each item on the checklist one by one. And then other people prefer to use a natural flow of their activities and then go through the checklist as a second pass through everything to make sure they covered everything. And it'd be interesting to see in anesthesia how people are comfortable using checklists. Do they use it as a step 1, step 2, step 3, step 4, or do they do things in a more natural way and then use the checklist as that second pass through?
Yeah,
Well,
I
Craig,
think
go on.
I was just going to say, I think it's somewhat contextual. You know, if you break checklists down to sort of normal procedure and emergent stuff, you know I tend to sort of, you know, like if I'm doing a machine check, I go through, I set it up, and then I step back, and then I sort of say, okay, did I do this? Did I do this? Did I do this? Did I do this? With more emergent stuff, I think just because of the adrenaline pumping and the chaos of, you know, your surroundings, sometimes it might be more effective to say, okay, you know, like we're going to go through ACLS and we're going to do this, and then we're going to do this, and then we're going to do this. And, you know, so it's, I feel like I approach it a little bit different depending on the situation.
And then the other interesting thing about checklists in aviation that might transfer over to anesthesia is that, of course, we always pull out the checklist whenever we have to do a procedure, whether it's a normal procedure or an emergency procedure. But there are certain emergency procedures that we feel that we need to have the checklist memorized, and we do those things from memory. Okay, we pull the checklist out to check our memory. Okay, but are there those things in anesthesia that are so important, that are so critical, that are so time sensitive that we teach new people? These are things you need to memorize. That in this situation, you do this, you do this, you do this, you do this. In aviation, you know, an engine failure on takeoff, you don't have time to be pulling out the checklist. You have to have those procedures memorized. Okay. And likewise, a loss of cabin altitude at a high altitude, you need to have those action steps memorized to take action immediately as you're pulling out the checklist to make sure you don't forget anything.
I find the fast track, Susilo talked about fast track surgery, and he did mention something that was different, drive-through laboratory. You know, this is innovative, this is different. Do you have any experience of drive-through laboratory, any one of you? Susilo, you still there?
Yes.
Yeah.
Yes, we have in Indonesia, because we finally found that if it is we can do that, then the patient will be happy. They are afraid to go to the hospital. Then we prepare the special car for that they can drive through. Then we take the blood, and then they can have the result after. We can email or WhatsApp the patient to know the result. It's not so many places, but we are starting to do that.
Definitely, that is a form of social distancing where you limit the contact with different people.
Yeah, sure. Thank you.
I think with us in Lagos as well, with the advent of this COVID-19 challenge, we have about 7 accredited laboratories. And one of the laboratories do actually have a drive-through facility for COVID-19 tests. And that has worked so very well. Just, you have to pre-book anyway. You pre-book, and you don't have to go to the hospital, just as he said. You don't have to come to the hospital at all. Pre-book, and it's as if you are driving through a normal house, so to say, with facility this test. And after the test, you go through, there's a barcode system through which, when the results are released on your phone, you don't have to go back to the hospital there or to the house or whatever it is. Using the barcode system, they'll send your result to you under 24 hours. And that's wonderful. If this can be possible with COVID-19 tests, I'm very, very sure with time, we can have this also doable for all the other laboratory tests. Thank you, Bisola.
You know, in Canada, one of the things that has surprised, I think, us, because we've often talked about sustainable healthcare systems and, you know, comparing low, middle, and high income countries. And it's very humbling because COVID has brought even a universal healthcare system like Canada to face its bottlenecks with renewed vigor. And one of our bottlenecks is laboratory services, right? So we have a huge demand on laboratory services, and it is one of our biggest bottlenecks, even for the preoperative screening, right? So, you know, yes, we run out of beds pretty quickly when we have demand. We also have run out of a number of commonly used perioperative drugs. And our laboratory system, as well as our staff, sometimes becomes the rate limiting step to increasing our capacity towards surge capacity to overtake our backlog in canceled surgeries. So I think it's been a really good lesson in the fact that all surgical systems around the world are at risk. And we all need to have this global perspective where we're not overdrawing one advantage, disadvantaging the other within our countries, but especially globally.
Anesthesia is very diverse, very interesting. I'm not sure if Rick is here. Is Rick still here? Because he did talk about training in Laos, and maybe he can talk a little bit more about his experience. Or
I don't see that he's
not here. Okay, okay, yeah. So it's really diverse. I mean, we have the bird's eye view of the whole system, you know. And if Carolina, was it Carolina that talked about the high mortality rates in Mexico? That is really, really painful to lose very high numbers of medical doctors and anesthesiologists. Someone asked why during the presentation, and if Carolina is there, maybe she can say something concerning that. It's really, really sad. Or Craig, maybe you can also talk about your experience in the US, the health workers.
Well, I mean, I think it depends on what environment you're working in. You know, I work in a children's hospital, and we've seen our share of COVID patients, but I don't think the experience in a pediatric hospital is really anything like what my colleagues in the adult hospitals, and particularly the ones that end up working in intensive care units, are dealing with. It's funny. There's not really any sort of transparent public data collection on healthcare workers who have been injured and killed by COVID. So there's a Twitter page that you can follow that lists all these healthcare workers, and it just goes on and on and on and on. I mean, it's like 1,000 people or something that have died, and that's not to say people that have been, you know, severely debilitated from COVID. I've had a few of my colleagues that have been COVID positive. For the most part, they've all done fine. The only person that I know, a healthcare worker that I know that has been severely affected was one of our, we have our pediatric gynecologist who's at our hospital, you know, at most once a week, but also maintains an adult practice. Developed severe COVID-19 and ended up on a ventilator in the ICU for a week or so. When he came back, he thought he was going to die. It was quite a life-changing experience for him. But I haven't. We've had a lot of logistical issues at my hospital and adult hospitals. But I do not know any healthcare workers who have suffered significant injury or long-term injury or have died from that. So,
Well done. We still have 65 people online. And it seems nobody want to leave. I'm sure that Dr. Ogunbiyi actually has another meeting after this, so he's going to be leaving very soon. Thank you very much for your presentation. Thank you.
Thank you so very much. It's nice being on the webinar. Thanks to you, Craig, and the A team.
Thank you.
A pleasure for me. Cheers.
Thank you, Obushina.
Thank you. Since this is the last, since this is the last series of the G4 Alliance webinars, maybe Natalie wants to say something. Natalie, maybe you want to talk about your experience with communication, Twitter, and so far, how has it been?
And tell us about tomorrow, Natalie, too.
Yeah. Well, it's been just an honor to work with all of these amazing panelists and to learn from you. I think I just have so much material that I can use for our advocacy efforts, and also so much more that I want to ask you. And I'd love to work with all of you on writing more, as Janet was saying, translating the work that you're doing into the language of policy. So I'm really looking forward to that. And I just wanted to let everyone know that tomorrow we have a Twitter storm. We're going to try to bring these messages out online and all around the world, have people tweeting this content. And we've put together a really nice tool that you can just click a post and post it really easily. So we'll be sharing it with all the panelists. So I hope you'll participate. Thank you so much.
Yes, and Dan, we have another meeting after this.
Yes,
Dan.
we do.
So we'll have to go prepare. Well,
yeah.
So thank you very much. So probably Dan wants to have the last word, and he can dismiss all of us.
Well, just to say again, thank you very much to our panelists, our moderator, the committee. This was a great webinar. Could not have been a more successful conclusion to what has been a fantastic series, but what a great way to end it on such a high note. So thank you for bringing in such a wide diversity of expertise and experience from different places in the world to different parts of the anesthesia community, and different issues, and particularly the discussions about anesthesia in these times of COVID and how we're going to move beyond it, from pandemic to progress. That was the theme we picked for this series, and you guys just nailed it. So thank you very much to all of our speakers.
Thank you, Dan. Thank you, Natalie. Thank you, Bisola. Thanks to all the speakers.
Okay. Bye-bye, everyone.
Bye.
Thanks. Bye-bye. Thank you, Janet. Thanks, everyone, for joining us, listening. Oh, thank you, Obushina.
My daughter is saying bye-bye.
Thank you, Obushina. Thank you.
She's been listening since we started.
Wonderful. He did a great job. Thank you.
Thank you.
Thank you. Bye-bye.
Bye, guys.
Bye.